So, Judd, it's great to see you, and as always. And so, I'm just really excited for us to talk about empathy and compassion and how we can be of service in the world and maybe leaving some loneliness and being together.
Sounds great.
Yeah.
Where would you like to jump in?
Hey, Koshin.
Well, one of my favorite things is to talk about empathy and compassion and the difference. And Chodo is like his least favorite thing is when I talk about that.
Why is that?
Well, because I've always thought that the difference between empathy and compassion is empathy is that neutral capacity that we all have. Like we walk into a room or walking down the street, and you can just feel people. You can feel someone walks in a room and they're sad, or they walk in the room and they're feeling angry, or and feeling having an acute sense of that is actually some people think that that's just a great quality, and but for me it's just a neutral quality. And insofar as a great torturer actually is someone who has to be very empathic to be good at their job. So it's, to me, it's a very extreme example, which is helpful, is like, because it really matters to me, like what you do with that empathic response is that we can, it actually feels good to care for people. To actually, so compassion is like, actually my teacher often is saying that, let's just suffer together, that we can tremble together, to be sweet and together, like, oh, it's hard together. And to me, that sweetness and of joining together and suffering is the beauty of compassion, I think.
Yeah, and
So the piece I don't like about the piece that I don't like, Judd, is the correlation between empathy and sadism. That's kind of like, a great torturer has to be empathic to know just when, I guess you're saying, just when to stop or just to be in the pain with them. So I'm not sure that I like that analogy, or even how true is it? Or what are your thoughts around that?
I think that's a great place to start. We can even look at this from an evolutionary perspective to start, because it might help us differentiate something that we may all, it'd be interesting to see if we all end up agreeing on this, but seeing that there are pieces that we would pull apart, that they're different. So from a survival standpoint, we as humans, and also this has been shown in other animals, but this may be something that is somewhat unique, as primates and humans go, being able to model other beings' mental states and their intentions and their behaviors as a way to kind of know what they're up to. And this, from a survival standpoint, helps us communicate and work together as a group. And so empathy, I like how you put that, Koshin, that, it's a neutral term, because it may be neutral in the sense of it's not necessarily seen as good or bad, but it's likely helpful for survival, because we can kind of get a sense of where somebody's coming from, what their intentions are. And we do that in our brains through a mechanism of literally kind of simulating other people's experience. And one thing I learned recently that's been fascinating to me is that this modeling of others' behavior may actually be linked to our ability, or to have evolved the ability to model the future, which we can put a bookmark in and come back to later, because when we model the future too much and we get stuck in it, that causes problems, whether it's from a Buddhist perspective or from an anxiety perspective. Being able to predict the future is helpful, but when we're simulating and getting stuck in the simulation, we're not actually living in the present moment. So let's come back to that. But I think this highlights the difference between empathy and compassion. Whereas if we take, at face value, I think, as you said, Koshin, this ability to put ourselves in somebody's shoes, I've recently looked up the etiology of empathy, and it's really, y'all probably know this better than I do, but it's something about really being able to put ourselves in somebody's shoes. That's kind of the literal etiology of this. And so it sounds contradictory to have sweetness in suffering when we are just literally putting ourselves in somebody's shoes. Suffering doesn't feel good. It's not supposed to feel good. And so how could there be a sweetness there? Well, I would argue that there isn't supposed to be a sweetness in empathy. It's there as a mechanism to help us be able to relate to others. Full stop. And if we go beyond that swim lane of being able to model others, we might actually get into trouble. And I think that's where I've seen this, and you all have probably seen this in your fellowship, but I've certainly seen this clinically, where clinicians, even in medical school, we were crudely, hopefully the training has gotten better since then. But, back in the day when I was in medical school, there wasn't a lot of training on, empathy, being able to empathize with your patients. Now, unfortunately, it's driven by these, patient satisfaction scores that are related back, of course, to money and billing. And so, the administrators, the bean counters that administer our jobs as clinicians are telling us, you have to get these scores up so we get paid more. And so they care about empathy or they care about patient satisfaction scores because it helps their bottom line. We care about patient satisfaction scores in the sense, well, I'll just speak from my own experience. I want my patients to get the best care that they can, and the best care, they're going to get the best care if we can see eye to eye, if we can relate to each other, right? Forget about their satisfaction. Their satisfaction is going to come along as a secondary factor of me doing the best job that I can and not ignoring them and not making assumptions and just being a good doctor. But what gets in the way of me being the best physician that I can is if I'm caught up in something. So if my patient's suffering and then I'm told that I need to put myself in their shoes and I'm suffering, well, now I'm suffering. And that takes away from me being able to help my patient. So I'll pause there. I think that may be a good place for us to dissect the difference between being in somebody's shoes and therefore suffering and having an alternative. In compassio, what I think it means to suffer with, literally, meaning that we can be with that suffering. We can still simulate it. And there may be a degree to which we need to simulate it. Like suffering is suffering on a crude level. We may not need to have, I don't need to have used every drug in the book to be able to relate to my patients with addiction. I just need to have a good sense and ideally a personal sense of what it's like to get caught up in something where I'm addicted, right? But I don't have to have used cocaine and oxy and fentanyl and, and this and this and this to be able to really be able to suffer with my patients. So I promise I'll stop there. What do you all think of that?
Well, first of all, just always feeling a lot of sweetness being with you, Judd. So, but for me, I think there's a huge difference. Like we often talk about that you can't, if you see someone sinking and you can't sink with them, like that's not helpful, right? If someone's drowning and you don't know how to swim either, and then you hold on to them and then you both drown, it's not so helpful, right? So, but I think that there's a way of, maybe it's really interesting because I feel like maybe there's a way of like actually learning so empathically, like saying like, wow, I feel your sorrow. I feel like you've been sick and like I wonder how you're doing today and feeling that towards you. And but to me, like becoming sick myself is not going to be helpful, but to realize like, oh yeah, I'll be sick too is helpful. And I have been sick and I will be sick. And so to not separate. And so to feel that sense of exchanging shoes, to use the image, but I think then to find out what's actually helpful and to have curiosity and about like, well, what would actually be helpful to you, and or what would be helpful to anyone that we're actually meeting. I think is really, that's where compassion becomes this active process that is, maybe it's the meeting of the ground of empathy, meeting suffering together, exchanging shoes, and then there's like this, it's actually so active, and then actually saying like, oh yeah, well, I don't actually know what your experience is with that. So like to be curious, because even if I've been sick before, I don't know what it's like for you to be sick, or for you to be sick, or for anyone to have their experience. And so I think that compassion is so led by curiosity and wonder with a loving attitude. And I'm thinking about one of our, since you brought up the fellowship, that one of our fellows, she's an amazing leader. She leads a residency program and a fellowship and is in leadership in her medical center, and yet felt this when she was getting home. She was crawling home and just like not kind to her partner, not kind to her kids, like all of her values were falling apart. So like where she was able to actually have compassion for her residents, for her fellows, for her patients, and then just felt totally drained. And so like learning how to rebalance through contemplation and being curious. Like she actually had curiosity. She realized that it was broken. She was feeling broken, her brokenness, and actually, and that was what got her curious. Like, I need to do something different. Or that really beautiful, one of my heroes that I love so much is Alan Alda. And he says, you're not really listening if you're not willing to be changed.
Yeah.
I mean, so to me, like, that's like the compassionate, like, are we really listening to ourselves? Are we having compassion for ourselves and others equally? Yeah. What do you think?
Right. I love this idea of when you talk about the sweetness of suffering. Sweetness of suffering. For me, it's the sweetness of suffering with others. I do a lot of work with groups of mainly, oddly enough, women who come to my bereavement groups. That's a whole nother topic of conversation. Men versus women come to grief groups, but I remember there's a couple of instances. One was it's usually an 8-week cycle, and during one of these cycles, a couple of years ago, there was one woman who didn't speak for about 3 weeks. We would go around the room, people would share their stories and their experiences of grief. And this one participant, she was just silent. She said, I'll pass. And then on around, I think it was the 3rd week, I said, Joan, I'll call her Joan, what's going on? You've been quiet now for a couple of weeks. And she said, I'm so embarrassed. I'm so hurt. I'm ashamed. We said, well, why? And she said, because both my sons suicided a year apart from each other. And I feel that I really let them down as a parent. And they're just so out of nowhere. And she stood up to leave because she was so wrought with her own pain and suffering and shame. And the 7 other women in the group just stood up and formed a circle around her. And it's so archetypal. So it was like watching a Greek tragedy unfold. They just stood up and they would not let her out of the circle until she broke down into tears and screaming and wailing. And there was for me, there was such a moment of sweetness right there. It's like, wow, this is empathy. This is compassion in action right now. This is so beautiful. And in my groups on a regular basis, I facilitate them differently. I ask them around about the fourth week. I ask the members of the group, the participants, to bring in photographs of the person that they've lost, so it's not so abstract. So we can see this person that they're grieving.
Mm-hmm.
They can tell us their history, and at the end of the group, the seventh week, I'll say, and I use a lot of poetry. And one poem that I use is by Marie Howe, "Tell Me the Whole Story." It's the spell. And I ask each person in the group to tell us the group something you haven't told us before, something you haven't told us yet in the group. What are you holding back? Don't hold back. And there's such a sweetness in that when they talk about how much they hated their husband because of his abusive behavior, how much they despised so and so, or how much they loved so and so. They hadn't just couldn't bring themselves to say it. Mm-hmm. That to me is when someone's been holding on to their innermost thoughts that they were afraid to express for so long, and they can let it out in front of a group of strangers. That to me is like so sweet. Wow. To see that to me is the sweetness in suffering and being with the suffering. We all know someone who's died, and so I can be there in that sense. Yeah, I know what it feels like to have lost someone that's died. I don't know your loss, but I know mine. Mm-hmm. To be able to go in there fearlessly and say, yeah, me too. Yeah, me too. One day, if Koshin dies before me, which is probably going to happen, being our age difference, it'll be wow. I mean, if I die before you, interesting.
Well, we don't know.
We don't know. That's it. We don't know. Yes, but to have experienced loss in myself enables me to be in empathy with another, mm-hmm. in that sweetness, which I think is even in our deepest grief, the sweetness, because mm-hmm. there's an opportunity for growth, an opportunity to unfold, to see more. I don't know.
Well, you're highlighting something that I think is really important, which is we have to be in a space where we can grow in order to learn and grow. And what I've seen with empathy fatigue and burnout, and we've done clinical studies with physicians and now with nurses and medical students to see, what are the patterns that contribute to these burnout. Some describe it as a burnout epidemic in healthcare. And I would say we are, whatever terms we use, it's not good and it's not going in a healthy direction. And even going back to what you said earlier, Koshin, around the physician that was coming home and, could have compassion in the clinic, but then, kind of broke down at home. We see the same thing where there are even habit patterns that are formed. And I would say there's one key differentiator between empathy and compassion. And I would say this is functional. So if somebody gets caught up in the definitional elements, I would say just place those to the side for now. This is really about being practical and pragmatic. I'm a clinician. I want to help, how can we actually help in the, kind of with boots on the ground. And what we find is this, when we take something personally, that seems to be a differentiator between empathy and compassion, where with empathy, we are literally taking that suffering on. And with compassion, we are literally walking with. And when we take it on, it's a heavy burden. And our natural reaction is when something's unpleasant is to make it go away. So we're actually tied up. We're tying our energy up in now something that's selfish. And I would say self-protective. It doesn't necessarily need to have that negative connotation of selfish. I'm being a selfish clinician. But we trip these very old survival mechanisms that were have evolved to help us survive. Whereas with compassion, we trip a different one that is probably even more useful for survival. Even Charles Darwin wrote about the importance of compassion, and some have taken that, from an evolutionary perspective to be, help, kin selection and things like that. But I think it's even broader if you think of all humanity as our kin. It goes way beyond just trying to help our, that selfish gene, so to speak. But if we go back and look at the empathy piece, so my lab studies habit formation and habit change, and it can really be broken down into 3 key elements for any habit. And so let's use empathy and empathy fatigue, and I would say empathy protective habits that I've seen form in the clinic and that we can actually address as an example. So any element or any habit is formed through 3 elements: a trigger, a behavior, and a result. So let's say that suffering is the trigger, like we see our patients suffering, and then our behavior can be one of many. I'll give some common examples. One is that as a physician, we're trained, we want to help. So we rush in, we want to save our patient. The joke in the ED is like, let's go save some lives, that type of thing. And they're literally saving people's lives. Not that other physicians don't, but it's more dramatic in the emergency department when somebody comes in with a sucking chest wound or something. So there's this rush to help. And then the result or the reward from a brain standpoint is, well, for this to be rewarding, it has to work. So what happens when the ED physician can't save the patient? What happens when the oncologist, they do the best, most evidence-based, practices available and their patient still dies, right? As you all pointed out, that is an inevitable end no matter how good our healthcare is. At one time or another, we're all going to perish. So if we take that as the reward, we are setting ourselves up for failure. That's one example, but let's go back to your the one that you brought forward from your fellowship. If somebody is, if they're let's say compassionate at work, yet they're kind of carrying this burden, right? They might I call it the take it home habit, where it's like they're worried about their patient, which is good. I would say thinking about your patient is good, but taking that worry home at night is not necessarily helpful, because worry by definition doesn't solve a problem. It just gets us stuck in a habit of worrying. And then what do we do at home? We snap at our family members. We're not available. It sucks energy from us, right? So there's that. And then there's anger habit loops where, the behavior is that we lash out in anger, whether it's at a, insurance denial or at something failing, or, there are lots of reasons. I think, I'm not sure they're helpful, but a lot of reasons that people can get angry in the clinic. And what happens? Well, that they take it out on their family. The clinician takes it out on their staff. Generally, they don't reserve it for their patients, but I've seen it. Unfortunately, we've all probably seen that as well. And so we can think of any of these, these are just common examples of habit loops where there's something that was rewarding enough that it gets set up as a habit loop. Let's use the anger one as an example. So somebody lashes out and then somebody steps up and steps in and gives them what they want. That can be training that person to say, oh, when I get angry, I get what I want. Not looking at the collateral damage that comes with that. Yeah. Or the take it home habit loop where they don't realize that it's affecting them and affecting their family because they're stuck in the worry, and it's couched or rationalized in their mind as, well, this is good patient care. It's not good patient care, and they just don't know it. Mm-hmm. So how does that fit with what you've seen?
Spot on. What I'm curious about, Judd, it's like I have such a selfish question. So
bring it out.
Because one of the things, like Chodo and I are, we're monks, and we're intuitive people, and mostly in the language of feeling and practice. And like, so we've been doing physician education for like 20 years or something like that. And we were always concerned about that, what you're talking about, like that kind of lack of connection, the breakdown of people feeling like, oh, they're bad at their self-care, they're bad at their wellness, like the word changes, and no, they're also bad at self-compassion. Mm-hmm. So they use all of these things as a weapon against themselves. And the other day you were talking actually with the fellows about the beautiful teaching that Shakyamuni Buddha, the historical Buddha, gave about community. Because for us, it's always been about that we felt like the medicine that people need to be good leaders, and it is true for us too. Like, we need people. We need, like, lonely monkeys or dead monkeys. Like, we know that, like, we need, but not just being around people, being around meaningful shared relationships. And that's one of the reasons why we love fellowship so much, because it's like the other word for sangha. It can be, but it's been appropriated by the medical community and doesn't often mean that. And so we're like kind of reclaiming that. But I'm just curious, like, what's your sense of, and let me know, like, so I'm just curious about, like, in terms of science, like, and you do all this beautiful research, and I don't understand the science of that. Do you?
Not a chance.
That's a great question.
But you know what I mean? Like, what actually happened? Like, we know from the work of like Bob Waldinger and other folks who, he does that Harvard study for the last 87 years following people. And it turns out, like, the big aha of that study is community matters for mental health and physical health and spiritual health. But I'm just curious, like, what your thoughts are about that.
I like to approach things from a mechanistic standpoint. So let's start there, and I think we can then we'll get to the answer. So I won't answer it directly, but let's start with the mechanistic piece. So if we look at the habit loop of, the any unhealthy or unhelpful habit loop of getting stuck in a story, like we've talked about, whether it's a clinician getting stuck in a patient's story, or whether it's a clinician getting stuck in their own story of, I'm not a good physician. Why didn't I do a better job? Why did I miss that? If they made a medical error, why did I lash out at my patient or my family member? Whatever it is, the natural tendency is to close down in a self-protective mechanism, right? Because when there's pain, the body naturally pulls away as a self-protection mechanism. If we put our hand on the stove, we don't push it farther into the flame. We pull away naturally. We don't even have to think about it. I mean, that's reflexive even, right? It doesn't even make it to the brain. It gets to the spinal cord and kicks back because we know from a survival standpoint, we have to react that quickly for survival. So it is a reflex, a literal reflex to pull away. And that's literally self-protective. So it's not to say that that's bad. It's to say when it's employed in a way where our natural survival mechanisms are getting co-opted in unhelpful ways and we don't see it, that's just what's going to happen. It's a really strong learning mechanism. And if we don't know that we've kind of learned something that's unhelpful and we don't learn to look for it, we're not going to see it. And so I would say that's I would hypothesize that that's a big driver in not even getting to the community, right? Because we could try to force people into community and say, look, the research shows that community's good. and that loneliness is bad. And then we can judge ourselves for not reading that paper and then judge ourselves for not doing what we're supposed to be doing, which is also self-related, let's say. So all of that is related to self. So let's take the next spin on that turn. And we can say, well, if this is how habits are formed, how can we leverage that very strong survival mechanism in a way that's not only helpful for the individual, but also helpful for the community? And ideally, if that's true, it's going to actually increase the propensity to lean in both ourselves, but also lean out for help from community. So let's take that same habit loop. Let's say a patient's suffering. And if we can recognize the pull of self, and we can recognize the unhelpful aspect of getting caught up in the habit loop, we can see how it's not actually serving us or our patients, which is a really good motivator to stop doing it, right? We see it clearly. We see it's not helping. It's through negative reinforcement mechanism, we can unlearn it. On top of that, our brain's going to say, okay, if that's not helpful, well, then I need to learn something that's more helpful. And so we can start playing with, well, what's it feel like not to take this suffering personally, right? I think a lot of people are afraid to even ask that question because they feel like it's going to show callousness or indifference, or, and these are actually definitional in the Maslow burnout inventory, right? This callousness. And in Buddhism, it's interesting. It's the near enemy of compassion is indifference. And I think that's worth saying twice in case people didn't listen carefully enough. Indifference is the near enemy of compassion, meaning that it can be mistaken for, or get, as people move toward compassion, they can get sucked into it if is critical here, if they are personally involved, if they're taking things personally. So indifference is a self-protective mechanism because it protects us from the suffering of others. And if we take this radical stance that it's not about us, and we say, wait a minute, I don't have to take this suffering personally. I can be with this suffering and actually be closer to it if I don't take it personally. Something crazy, radical, magical happens, which is that we see, oh, there's this suffering and I can lean fully in because it's not about me. And now this sweetness, this openness happens because I can be open to somebody's suffering, especially when my goal in life is to help others. And there's no pain in that, in the sense that I'm not personally pained by it. My heart quivers, absolutely. There are tears, there's all the natural compassionate response, but it's not about me. And we've actually seen this directly. We did a study that we published, I think, last year with physician burnout, where we can actually reduce it quite a bit with very little amount of training. And this training is now free on my podcast. Anybody can listen to it. But the first place we start is helping people differentiate empathy from compassion, and just that understanding, and then having some very simple ways to explore it in our own experience can be really helpful. I think we got pretty significant reductions in burnout just with a 7 by 15-minute audio course, And I think this is also likely what your fellows see going through your fellowship training, is that when we can learn to differentiate taking something personally and not taking it personally, the world opens up to us. And I've used that word intentionally. The world opens up because self-protection is about closing down. Yeah. And when we don't take something personally, we don't have to protect ourselves because we're not taking it personally. So we can open up. So we open to the suffering, which also subsequently opens us to learning. So we're now open to being open to learning, right? This is what Carol Dweck calls growth mindset. And also, we're open to community. So we can see when we need to reach out for help as compared to being embarrassed, right? That can be a habit loop itself. Or we can feel like, we should be tougher, which is something we learn to, in medical school, what do they call it? We need to armor up, to protect ourselves. You know what? If there's nobody to be harmed, there's no armor that's needed, and that's energy that can be repurposed. So we can say, I'm suffering, or I need to tag out. Can somebody tag in for me? And instead of seeing that as a weakness, we can see it as a strength, right? Brene Brown talks about vulnerability as strength. And so this is where I think it comes back to community, is that we have to see where we are getting in our own way, because when we can see that, we can see that naturally we can get out of our own way, and that opens us to community, and it helps us see how valuable and invaluable, I would say, community is.
Yeah.
You're my community. Just sitting here listening to you both is so heartwarming. I love that expression, heart quivering. It's just that's such a visual right there. It's so visceral. It's like, my heart's quivering for you, and for me at the same time. My heart is quivering for you. I remember in the early days of chaplaincy training, my supervisor, who happened to be a Buddhist monk, said, the first thing we have to learn is that with the patient, to know what's yours and what's mine. To be able to companion someone. The word chaplain means to be able to put one's cloak around you, to keep you the vision of being kept safely, being wrapped in this. And again, that takes me back to those beautiful women wrapping themselves around this woman who was suffering at the loss of her children. But the idea of just, I can be with you, I'm on this journey with you, but it's yours and not mine. Just to me, it's like that moment of recognition. It's like, I don't have to take this home with me. Mm-hmm. When we hear in our fellowship, surgeons are nearly always, all of them are saying, when I get home, X, Y, Z, and it's not pleasant, because they're not able to leave it there with the patient. Mm-hmm. It's not to say that they're not entirely. It's not to say that they are not involved, because there is an involvement, of course, but it's not enmeshed. We're a company, but we're not enmeshed with them. It's such an important moment to say, this is yours, this is mine, and we're together, but we're not like this. We're like this, holding each other. Because also, I think for me, certainly my experience, there is a holding of each other there when you meet on that beautiful, beautiful empathic level. You're holding each other in one way or another.
Yeah. That reminds me of, I love that, holding each other. So the image comes up of batteries, and batteries can be very helpful for any device that they're serving. Yet the battery itself is not helpful if it's not functional. And so if we are that battery for the relationship and helping our patients, and the battery gets completely depleted, the battery is no longer useful or helpful. And so being able to go home and recharge is actually critical for us being helpful in our jobs as clinicians. And so, we can say it's actually detrimental to my patient care to be so enmeshed that I can't disengage and recharge.
Mm-hmm. If we see I know for myself, seeing my home life as my charging station, to charge the batteries, to go home and to be caught up, to be wrapped in the unconditional love of our cats. I have 2 huge cats, and of course with you, secondary to my 2 Maine Coon cats. But no, to be able to go home, to know that you're walking in a place that will that does have the energy, that does what will recharge my batteries, whether it's looking out at the panorama of Manhattan from my rooftop. It's just because that's the charging station for me to be able to go, yeah, I can do this. I can go in tomorrow and face the world again tomorrow, face my hospital, face my patients.
Yeah, I was in the same kind of thing about batteries. I was thinking, I was just in Japan and visiting this incredible nun named Shindo Yamaroshi. She's just like this incredible being, so as many people who are quite wise, she's very funny and very grounded and very doesn't take herself so seriously, and yet is a serious person. And but she was using this image. She's 93 and she's just so energetic about practice and so clear. And she was talking about, the point of practice is that and this could go for, our lives, right? To go into outer space, to be at one with all things, she said. A rocket has to have a number of boosters, and it's not just one. And just like one rocket brings it to a certain level. And then so she was saying that like one is like our awakened mind, and the other one is the Dharma, and the other one is Sangha. And that's what brings you into being amongst the stars. And it's such a beautiful image, that really was inspiring, that we do need that. And what does that? What fuels that? And I love that she was talking about that, the teaching itself and community and being awake to what we need is what actually brings us there.
Yeah.
So cool.
I love the way bouncing in the tune. It brings us there.
I know she was like that. She was like, I mean, how amazing, right? At 93, she was just like, yes. And that's what's possible.
Well, that brings the image of these wholesome habit loops, right? If we can first recognize the unwholesome ones, where we are being self-protective, where we're taking things personally, where we're, whatever they are, and see that they actually deplete our batteries and prevent us from being the best people that we can be, that helps us let go of those. And then on top of that, if we can see how wholesome and even recharging our, compassion is, where we're walking with suffering, we're exploring the boundaries or the boundarylessness of compassion, right? I love how it's one of these 4 divine abodes that are considered boundarylessness. And they just grow the more we lean into them. So when we can see how being with suffering doesn't deplete us, and in fact energizes us, because we know that we did everything that we could. We don't take it personally. We can go home, get some love from our cats or whatever. And then also we can know what our limits are instead of trying to be the hero. There's hero habit loops run rampant, unfortunately, because that's something that's trained in the culture of medicine. Gotta be tough and strong, and don't have to eat or pee or sleep or anything. When we can see, like, wait a minute, I do need to tag out, and that's actually the best thing for my patient and for me and for the whole system, we can lean into that. And we see, from an evolutionary perspective, we can lean into that reward-based learning system that we've been talking about and see, oh, actually, this is the most helpful thing, and it feels good. And when we can see that it feels good, then it's going to naturally reinforce itself. And so maybe a way for us to kind of wrap this up, I love to give people, pragmatic take-home things, is, like, one, we can just see how painful it is to take things personally. 2, we can see how good it feels to be with suffering, to not be afraid of the pain itself, right? That helps us differentiate, oh, I'm taking it personally versus not. and then see, oh, wait a minute, I can lean in. And then 3, seeing what leaning in feels like. Now, I know typically there's 3 points, but I'm at a 4th one here, which is when we can see all of those things, we can develop these healthy habits from an individual perspective. And then the 4th point is we can see how valuable and invaluable Sangha is. You know, I love one of my favorite suttas in the Pali Canons where the Buddha's cousin Nanda says to him, you know, this holy life is half of the, you know, the community is half the holy life. And the Buddha says, don't say that, Ananda. It is the whole of the holy life. And so we can really see how we are all in this together. There's no other way. We can't do this alone. And that leaning in, opening to our vulnerability, that's really where the strength lies, is in numbers, in all of us together.
Well, it is always a joy to be with you, Judd. And in community. I feel like these circles of us being together is just another way that it's so important, making time to be together, to talk about what matters is so nourishing. So thank you so much. Thank you so much.
Thank you so much. Thank you so much.
Thank you so much.
No, thank you.
It is a joy.
John, such a pleasure to be with you as always.
Yeah, likewise. I'll just mention, if this is helpful, you know, we've now put the research that I mentioned earlier is now freely available on my Dr. Judd podcast. So if anybody wants to listen to those now evidence-based trainings, they're freely available.
So great. That's terrific. Yeah. Thank you all.
Take care, John.
Great. Thank you.